We're going to be talking about the journey of diagnosis or to diagnosis. And I know that we've heard from multiple people through the years about, just the challenges of getting diagnosed. For some, it was a bit delayed, maybe frustrating, and there's a lot of different reasons that could be. And, we want to dive into some of that, as well as the importance of seeking second opinions if necessary, and how you can go about that. So with us today to have this discussion is Dr. Jill Farmer, and you may have seen her on a PMD Alliance program before. She is one of our favorites and frequent
Thank you.
flyers in our programs. And she is a movement disorder specialist in New Jersey, and her specialty is, of course, movement disorders, Parkinson's disease, medical and surgical management, botulinum toxins for dystonia, spasticities, and as well as managing functional movement disorders. She has a big telemedicine practice, and we're going to be talking a little bit about that. But I want to welcome Dr. Farmer to this
Thank you.
conversation.
Hi, happy to be here.
Awesome. And just to give you guys just a fair warning, we're not going to have any slides today. It is recorded, but there aren't going to be any slides to share. We are going to do this fully conversational style. And Kelly, I don't know if you've already done this, but from my view, can you spotlight us? You might have already done this. I had an issue with it yesterday, but there we go. So I first want to kind of just dive in, and please feel free, folks, to drop your questions in as we go along. But I want to talk a little bit about, from your experience, Dr. Farmer, or even what you've seen in some research, what is the typical length of time it takes for people to get a diagnosis?
Sure. So for patients that don't have a tremor, because still to this day, whenever someone thinks of Parkinson's, medical professionals included, they will think of a tremor. For patients that don't have a tremor, their journey to a diagnosis can be increased by anywhere from 3 to 5 years because it's rigidity or balance are often the presenting symptoms, and they're often then attributed to other things, whether it's, back disease, lumbar stenosis, or whether it's arthritis or, just getting older, for the rigidity factor of things. So unfortunately, without a tremor being a early presenting symptom, those patients tend to be delayed. For patients that do have a tremor, the diagnosis can sometimes be made more quickly. However, it's usually access then that can delay the diagnosis because of wait times to get into clinics and movement specialists or even neurologists in whatever geographic region they might be.
Yeah. Curious, how many doctors on average do you think it typically takes for someone to get a diagnosis, if they, especially if maybe they don't even know about a movement disorder specialist?
Sure. So usually it starts at a primary care physician, and then the primary care physician will refer on to a general neurologist. And then the general neurologist may or may not refer on from their own clinic. Oftentimes, when we're dealing with tremor predominant symptoms, those patients may be initially thought to have essential tremor and not Parkinson's disease, especially if the patient is on the younger side. Usually, if it is someone that fits the classic phenotype that was taught in medical school, an older individual, stooped posture, tremor, shuffling gait, then that is something that a general practitioner or a neurologist might feel comfortable saying immediately, like, this is Parkinson's disease. But if it isn't that classic phenotype, or someone's on the younger side, or they're missing the tremor, like I was saying, it can be 3 or 4 doctors before they get to a diagnosis. And it doesn't always have to come from a movement specialist, a very, well seasoned and someone who has a lot of experience in either primary care or in general neurology might be able to make the diagnosis. But sometimes, like I said, for the non-classic presentations, it's only until someone gets to a subspecialist that they're able to get the diagnosis.
And I know that there are a lot of communities where they just don't have access to a movement disorder specialist, or even like hundreds of miles to get access to
Mhm.
that. So what happens in those cases?
So in those cases, it is obviously an issue of access, and sometimes patients are just not diagnosed. They are delayed to their diagnosis or just not diagnosed at all. With the influx of utility of telemedicine, since the pandemic, there wasn't many positives of the pandemic, but the utility and access of telemedicine may be one of them. That hurdle of distance may be a bit less since patients are able to have a virtual visit. And I would encourage patients, if the wait times are long and they're not able to, physically go into an office to see someone, if a virtual visit is an option, take it as an option. Movement disorders is an incredibly visual field. Yes, there are times where we have to lay our hands on patients, but you can do 9 out of 10 things via a video that can give you a good idea of the type of movement disorders that somebody has. And that might be enough just to sort of start the process, whether it's additional testing that's needed or a trial of medication that might be needed until an in-person visit is available. So I I happen to be a big advocate of telemedicine, so I encourage patients to utilize it if it can help them secure an evaluation and access to resources that in person isn't as feasible.
So, can we dive in a little bit about some of the things that might cause or contribute to delayed diagnosis? And you've already mentioned them a little bit:
Mm.
age, gender,
Sure.
um, and maybe even some of, like you're saying, the non-tremor dominant
Mm.
forms of Parkinson's. Can you talk about those a little bit and how those contribute to that?
Sure. Gender plays a big role. You also have your guest probably know Dr. Indu Subramanian. She's on quite often. She did a wonderful research article on gender and diagnosis and delays to disease and Parkinson's disease. And it's not unique to neurology. It is well known throughout medicine that oftentimes it takes women multiple visits to be able to advocate for their symptoms that they're experiencing to be taken more seriously than just something that is related to stress or related to hormones or whatever it might be. And it is true, if someone comes in with a tremor and they are a woman on the younger side, it is documented that, the idea of Parkinson's might be low on the differential, but a thyroid condition may be high. And that's not to say that that's inappropriate to think about. The thyroid disease can cause tremor, and thyroid disease is very common in women. So the rationale makes sense, but it doesn't end there. So that's the problem where, thyroid checks out and, they're having some constipation issues. Oh, well, it must be IBS because, of stress and, the natural tendencies of women to have IBS-C or IBS-D or whatever it might be. And then they're having sleep issues. Well, again, it's related to stress or menopause, perimenopause, whatever it might be. Again, all of this has merit, but when you take a step back and start to put constipation and sleep fragmentation and a tremor together, it's clearly something that can also be a prodrome or presentation of Parkinson's disease, but it's not commonly thought of on high on the differential in women, particularly younger women. So that also delays the diagnosis.
And do you see additional issues with women, men of even of color? Like they're
Absolutely. And that is, again, far beyond even just neurology and access to this aspect of neurology. There is fundamental discrepancies and inherent medical racism that has made people of color apprehensive about going to the doctor, fearful of speaking up when it comes to their symptoms, not wanting to, contradict a doctor or be an advocate for themselves, believing that the medical professional and the medical establishment would cause harm should they treat the patient. So there are many reasons why patients of color historically do not necessarily get the care that they need nor seek out the care that they should. Um, from a specific Parkinson's feature, lots of times there is a, particularly when it comes to tremor, when it comes to slowness, when it comes to rigidity, there's this um, there's this feeling that it is age, that there isn't necessarily an underlying condition that can be treated, but that there is something that, my father had that, my mother had that, my uncle had that, and they just dealt with it and it was fine. So it is that same idea. Well, actually, there was a condition that we can manage and treat and try and intervene for symptomatic benefit. But again, with the historical racism that has been seen in medicine, it is hard to get to some of the fundamentals that we could do in order to be able to help patients to get the access that they need.
And I think you bring up a really good point, because it's not always just the physician side and getting to the right people and being heard when you're describing ambiguous symptoms and putting the puzzle together. It could also be people minimizing symptoms or having fear of symptoms, or even like cultural practices or beliefs that that impact that. So there's that side of the coin as well.
Absolutely. And I mean, PMD Alliance advocacy groups, Parkinson's Foundation advocacy groups, a lot of the impetus of education is to try to get out into communities of color to provide this education. But again, it necessarily can't be someone with my face that does it. So you have to engage the community leaders that is going to be able to help reinforce this idea of, educate yourself so you can be your own best advocate, so that you're able to go and have a conversation with the medical provider that you see, so that you can feel confident about the symptoms that you're having.
And I'm just curious if anyone or all of you would be willing to drop in the chat, how long did it take for you to get a diagnosis? I'd be just curious. Some people were lucky and they were diagnosed immediately, but I know there's quite a few people that have actually had a bit of a delay in that. So if you're willing to share that with everyone, 2 years.
And
So that's
especially if it's, again, not that classic presentation, but a potential atypical Parkinsonism or something like that, where things are chalked up to other systems of the body, cardiovascular, GI, it is something that can absolutely delay the diagnosis.
so far we've had 2 years, 3 months, and 4 years.
Mhm.
So 4 years is a long time. So, um, so you mentioned this. I'd like to go back and dive into it a little bit more. I know people have heard the terminology of prodromal before. Don't make any assumption that everybody understands the language of that. So can you talk a little bit about the prodromal periods? What are those symptoms? How long do they present before maybe the motor symptoms? Because I think that's important now,
Right.
in our understanding.
Absolutely. So prodromal just means the time it takes prior to classic symptoms being present, classic physical symptoms being present. And this Parkinson's actually has quite a long prodrome, if you will. And the reason for that is by the time physical symptoms present, that tremor, that rigidity, that slowness, patients have already lost about 60 to 70% of their dopamine. So something is happening while that dopamine is depleting. And the way that presents can be anything but motor symptoms. So it can start with sleep. So some people will have very vivid dreams, act out their dreams, talk in their sleep, punch in their sleep, whatever it might be. These dreams are usually very emotionally charged. You're fighting someone, you're chasing, you're protecting someone. That can predate a diagnosis of Parkinson's by decades, 20, 30 years, if not more. Not everybody gets this. Some people will experience this during their Parkinson's journey. It has no bearing on severity or anything like that. It's just simply a symptom that could raise awareness that this might be something we need to look at in the future. Same thing with loss of sense of smell. So pathologically, the reason why these symptoms start to occur is because the inclusions that are in that invade the cells, that cause the cells not to be as functional as they otherwise would, sort of go in this direction. So they move up the brain stem, up into the, the meaty part of the brain, the actual cortex and things like that. And as it's hitting parts of the brainstem, the first part it's going to hit are things that happen automatically. So stuff like constipation, stuff like sleep patterns, stuff like temperature regulation. Then as it goes a little higher, it kind of hits where your nose is. So there's two little offshoots from the brainstem, the olfactory nerves, and it can cause them not to function as well, which means you lose your sense of smell or sense of taste. And then as it goes higher, that's where you start to reach the motor pathways of the brain, the basal ganglia, things like that, that you may have heard of. And that's where the motor symptoms start to come into play. And then as you go higher, you reach even more cortical features or things like executive function. So that's where thought processing, memory issues, and things like that can come into play. So it moves slowly over years to go even this short distance. So if we have the ability to put together the pieces more quickly, the question is always, if we intervene sooner, is there something we can do about it? And right now, we don't have anything that delays progression of the disease. But we do know that people that are managing their symptoms, whether it's medically or with exercise or something in between, that they symptomatically do better for the long haul, as opposed to somebody that just watches and waits. So the prodrome can be important. And it's something that if someone in your family has Parkinson's, you want to be aware of, so you can sort of keep an eye out on, other individuals in the family, the generations that are coming behind, to see if they're experiencing anything, so that they may be able to get an intervention sooner rather than later.
And that's important. Like, that's one thing you can control is how much exercise you do and
Absolutely.
diet that you have. So
Yeah. And I think if anybody also listens to, gets the LinkedIn or webinar and stuff, Rachel Dullum just put out a video today about diet in Parkinson's, and it's the Mediterranean and the mind diet, not rocket science. It's the diet that has the most data behind it. But there is a reason it hits the highlights. It's lean fats and lots of fiber. Fiber is so important for not just food absorption and constipation and medication absorption and all of that. It is the thing that just lubricates the digestive system, that makes everything function. And as a whole, the diet of the United States is incredibly low in fiber. So if you did nothing else but increase your fiber, that would be huge. And obviously water, because that also helps with dehydration and with absorption and everything.
So I'm curious if there's been any research around the different prodromal features, whether they correlate with different motor features, maybe some of the later non-motor symptoms as far as like subtypes.
So they're looking at it. There is not anything that is 100% causal. Like there's some correlations between if people have early onset Parkinson's, if they have a particular genetic phenotype, are they more sensitive to developing dyskinesias and things like that. For people that do have REM behavioral sleep disorder that go on to develop Parkinson's, is there any concern for increase in non-motor symptoms of cognition or psychosis, things like that. But there isn't, I would say, at least not that I'm aware of, something that is specific. If you have this genetic marker, you will go on to have this trajectory of Parkinson's features. It's more of a relationship than it is, like I said, a causality.
So you mentioned the atypical Parkinsonian symptoms. Can you talk about some of the challenges and early differentiation between
Sure.
those?
So there is a spectrum of Parkinson's and Parkinsonisms. Classic idiopathic Parkinson's disease is here, and then we move down the line towards its mimics. Within Parkinson's itself, classic regular Parkinson's, there's three subtypes. There's tremor predominant, there's akinetic rigid or very, very stiff, and then there's postural instability gait predominant, which, balance issues are an early presenting feature. Even within those three, people respond differently to medications. Certain symptoms can be more prevalent, like the balance issues, things like that. Now, Parkinson's, of those three, what we call idiopathic or classic Parkinson's, it should still progress in a rather slow fashion. So you will have these symptoms, they will change over time, but nothing is incredibly rapid. So it's not like you hit a plateau and you fall off a cliff, you hit a plateau and you fall off a cliff. It's more of an insidious change. If you start to have a quicker change to your symptoms where the balance issues are becoming out of proportion to what would be expected within a year, within 2 years' time, if your autonomic things, whether it's sleep, constipation, blood pressure issues, are a problem that are out of proportion to what you would expect to classic Parkinson's presentations, then you might start to think you're moving into some of these atypicals, because in the atypical world, the non-motor features tend to be more prevalent sooner than they are in classic Parkinson's presentations. But you can see why it's a little bit hairy, because if you have postural instability gait problems and your balance is an issue and you have retropulsion and falls, then someone may be thinking it's blood pressure related, or if it could be visual related, that you're not being able to have a full range of vertical gaze, or be able to look down easily. So that's leading, and that can then sort of muddy the waters, and you're thinking it's an atypical Parkinson's. So really understanding the different features of the different types of Parkinson's, but it's the duration of time that these features are present and the severity of them as they become problematic, that really is what helps us tease out clinically where someone falls on the Parkinson spectrum. And just to put names to what I'm saying, as I said, there's those three types of Parkinson's, but then atypical Parkinson's used to be called Shy-Drager. Now it's called multiple system atrophy. Then there is a progressive supranuclear palsy or dementia with Lewy bodies. And these different entities, while they're all under the Parkinsonism umbrella, have very different clinical presentations. And usually the multiple system atrophy, the dementia with Lewy body, the progressive supranuclear palsy are going to have a quicker course of severity. They're not going to have that same responsiveness to medications that idiopathic or our classic presentations of Parkinson's disease have. And they are going to be more pronounced with things like blood pressure issues, falls backwards, swallowing difficulties, and cognitive changes, particularly with dementia with Lewy bodies, with hallucinations and things like that.
And why is differentiating these so important?
So it's important because you want to have patients be able to have an appreciation of what their clinical course will be, so they can obviously prepare appropriately. Many of these things will involve conversations about care that's needed going forward, what is realistically able to be done within the family, or if other individuals will need to be brought in to help, or if they'll be need to move to different locations. But also, medication is important in managing all of this. While we don't have anything specific for the atypicals, and we use the same medicines we use for Parkinson's in those cases, how we expect someone to respond to them is going to be different. So usually patients that have an atypical, let's say a dementia with Lewy bodies, even if they're stiff and rigid and we use carbidopa levodopa to help that, we have to be aware that the carbidopa levodopa may worsen the hallucinations. So we might need to address hallucinations a little bit more aggressively before we address the motor symptoms. So it does change our clinical decision making to some degree, even if it doesn't necessarily change how we manage. Because like I said, the the tools we have available, from medications to rehab strategies and all that, are going to be used regardless of where you fall on the spectrum. It's just our expectation of how they'll be utilized and what benefit it might serve.
And are there certain signs or red flags that people should consider or be on the lookout for any of these that might alert them that it may not be the typical Parkinson's?
Probably the biggest, not, I won't say, I'll say red flag, but it doesn't mean like if this doesn't happen, it means you're automatically atypical. That's not what I'm saying. But the thing that maybe should give you pause first and foremost is how well you respond to medication. Because like I said, carbidopa levodopa is the gold standard. Usually if someone's having motor symptoms, we're going to give them medication, and we're looking for any response. It doesn't have to be a light switch response, but any response whatsoever will let us know clinically, basically like diagnosis by treatment, if you have a dopamine deficiency. Now, if you're on carbidopa levodopa, you are slowly titrating it up, you're taking, say, 2 pills every 3 hours, and you're still honestly really not noticing a thing, or it's causing you to have side effects where your blood pressure is really low, or you're having, hallucinations or things like that, that responsiveness to medication is not what we would typically expect from someone with a classic presentation of Parkinson's disease. So that might then make us think, are we dealing with an atypical? Again, if non-motor features are present early on. So if you have some slowness, some stiffness, maybe a little bit of a tremor or no tremor at all, but your blood pressure is just really labile, that might make us think we might be dealing with an atypical. Or if you have a change in your cognition accompanied with hallucinations. So hallucinations are a hallmark of dementia with Lewy bodies, and hallucinations can also be seen in Parkinson's, but typically not immediately at the time of diagnosis. It's not a presenting symptom. So that might be something that also leads to the, you know, discussion of the differential or the concern that we might be dealing with an atypical Parkinson's.
So I know people have heard it said, that this is a clinical diagnosis, but there are some tests and workups that are done as part of that. I wonder if you could review some of the testing people might undergo.
Sure. So the one that's now been around for a while that might be most familiar is the DAT scan, DAT. It stands for dopamine active transporter. Now, this is not essential to make the diagnosis. To make a diagnosis clinically, like we just mentioned, it's still based on the motor features, again, which is the caveat as to why some people are delayed to the diagnosis, but you need 3 out of 4 features, the 4 classic features of Parkinson's: tremor, slowness, stiffness, balance issues. So fancy words: tremor, postural instability, bradykinesia, and rigidity. If you have 3 of the 4, so again, doesn't have to have a tremor, then you make a presumptive diagnosis clinically of Parkinson's disease, you provide medication, you see how the patient will respond. For those that don't have a clear-cut picture clinically, the DAT scan was the first biomarker that we had that was most readily clinically available, that was helpful in just confirming a dopamine deficiency. So what that means is it doesn't technically diagnose Parkinson's. It diagnoses that you have a dopamine deficiency. it doesn't stage Parkinson's. So if someone has a terrible DAT scan, meaning that you get a report back that it says there's no evidence of dopamine uptake in the brain, but all they have is a very subtle tremor and maybe a slight decreased arm swing, it doesn't correlate to the study. It's not meant to. It's only supposed to confirm whether someone has a dopamine deficiency. It doesn't give any indication towards progression, nothing like that. There are fancier versions of the DAT scan that are typically used in research settings that do quantitative analysis that may be able to elucidate a little bit more by way of staging or progression and impact. But the one that you get at your run-of-the-mill, hospital and, imaging center is going to be the straight run-of-the-mill DAT scan that just confirms a dopamine deficiency. Now, that spectrum of Parkinsonisms that we were talking about, as you move further down the spectrum, the impact of dopamine deficiency actually gets less and less. So there is the biggest cousin of Parkinson's, multiple system atrophy, may still show a dopamine deficiency. But as you get to dementia with Lewy bodies or cortical basal or degeneration or progressive supranuclear palsy, these might have less and less of an evidence of a dopamine deficiency on the DAT scan, but you still look Parkinsonian clinically in the clinic. And that's where the newer biomarker can come into play, which is the skin biopsy or the SIN1 test. This looks at the pathology. So the gunk that accumulates in the cells that cause the dopamine cells to die off in the brain is a protein called alpha-synuclein. Parkinson's, multiple system atrophy have alpha-synuclein. As you get further down that spectrum, things like progressive supranuclear palsy and CBD, they don't actually have alpha-synuclein as the main protein. They have a different type of protein called tau. This is the type of protein that's seen in Alzheimer's. So there are other tests that can be used to look for that. But the skin biopsy, the SIN1 skin biopsy, may have the ability to say where you fall on that spectrum. So if it comes back positive for alpha-synuclein, we know that we're dealing with a Parkinson's picture or possibly MSA. If it comes back negative, then we might be dealing with one of the other mimics of Parkinson's, like a CBD or a progressive supranuclear palsy, things like that. Clinically speaking, I still rely on the DAT scan quite a lot. Do I then have patients go and get a SIN1 skin biopsy if they're not responding the way I expect? I can't say that I've used it a ton because one of my tenets when I order a test is it going to change my management? So if I have someone that is not responding the way that I expect, then clinically I'm already thinking I'm dealing with an atypical Parkinson's. And I know what clinical features I'm looking for, and I know how I'm going to adjust my medication to address it. I think it's incredibly helpful for research studies and things like that, where you want to have the right patients in the study because you want to have whatever intervention you're doing have the best chance of success. And one of the reasons why some of our Parkinson's studies have failed is because we're mixing in atypical Parkinson's along with classic Parkinson's disease. And as I just said, we don't expect those patients to have the same response to medications as somebody with classic Parkinson's would. Now, if there is a question of like, we really need a more definitive diagnosis for a number of reasons, then by all means, the SIN test can be quite helpful. It's something that I'm incorporating into my clinical practice, but it's not something I use as much as the DAT scan at the moment.
And we had a question if you could explain what the cogwheel test is.
Sure. So cogwheeling is a marker of rigidity. So it's a marker of stiffness. And typically how that's tested in the office when you're face to face with someone, you roll the wrist and you kind of move the elbow back and forth. Or if someone's sitting down, you move you at the hinge of the knee, you move the leg back and forth, and you look at that range of motion to see if it is restricted in some way. You can also feel it. You can feel sort of a catch at the joint, which some people describe as, sand in a gear. Other people will describe as, a zipper that's not moving as easily and it catches. So that is a marker of rigidity or cogwheeling. Cogwheeling is one of the hallmark features. Rigidity is one of the hallmark features of Parkinson's disease. Now, getting back to our telemedicine visit, clearly you can't reach through the screen and do this, but there are other markers of seeing it. If I am examining a patient and I ask them to pronate and supinate, or I would not say that in the visit, I would say, can you turn your hands like you are, screwing in a light bulb or something like that? If they're not getting their hands over all the way, then that's a marker of rigidity. If when I'm watching them walk, they're not swinging their arms as freely as I would expect, that's a marker of rigidity. When I ask patients to tap their fingers, if they're tapping and all of a sudden it's getting smaller and smaller, or what we call decrementing, that's a marker of rigidity. So there are still ways to tease out rigidity, even if you're not physically examining a patient.
And you mentioned staging. So can you talk a little bit about that and what role that has?
Staging for
Where Parkinson's is, when you said that like the DAT scan, it doesn't tell you the staging, and it might say their dopamine is not there, but their symptoms aren't necessarily that extreme.
Sure. So the staging is again a residual classification based for research, is where it comes from. Stage 0 to stage 4, stage 5. The it kind of can give an expectation of where patients will live with their symptoms. The reality is that most patients with Parkinson's, even from the time of diagnosis, will live somewhere between stage 2 and stage 3 for the duration of their disease. And it is based on what side of the body the symptoms are present, how they respond to the medication, how long they've had Parkinson's disease, the ability, the impact of non-motor symptoms, the impact of balance and falls, and their need for assistive devices. So that's sort of where we get the classifications of where someone's falls. Stage 2 means you have some symptoms on both sides of the body. You get some response to your medication, and you are able to walk fairly independently, and falls are not as big of an issue or a concern. Doesn't mean you don't fall, but it's not a predominant issue that requires intervention. And like I said, that can be a pretty big stage, a pretty wide range of what that is, of where patients will live. Stage 3 usually involves a little bit more of a concern for balance and maybe bringing on board some assistive device that might be needed from time to time. And then stage 4 and beyond is really marked impaired functional status. But like I said, most patients from the time of diagnosis to the duration of their disease will be between stage 2 and stage 3.
And I'm glad that we had that clarification, because we just had a question. So this is not like cancer staging that indicates life expectancy. And I think people
No,
hear
not at all.
staging,
Right.
and it sort of freaks them out a little
Yeah.
bit.
No, I'm glad. Yeah. So, I mean, you've all heard and you can roll your eyes at it because it's true. Like Parkinson's does not shorten life expectancy. And that is true. Technically, it is semantics though, because if you didn't have Parkinson's and you didn't choke on something or you didn't fall and hit your head or whatever, then obviously it plays a considerable role in morbidity and mortality. But from a pathology point of view, Parkinson's does not shorten life expectancy.
And then we also had a question, because you mentioned in terms of like the atypicals not responding to the medication, and we know typically they're given first the carbidopa levodopa. So they want to know, like, does non-responsiveness to a dopamine agonist like a Mirapex also, could that suggest an atypical?
It doesn't really. It is now, if you have a wild adverse reaction to something like a dopamine agonists are great medicines. They mimic the way dopamine works in the system, but they do have their side effect profile that you need to be aware of, particularly drops in blood pressure, hallucinations, impulsivity, compulsivity. Those side effects also tend to be dose dependent. So if you were given an incredibly low dose of a dopamine agonist, and even at a very low dose, you start where you didn't have before hallucinations, you get hallucinations, or you get a very profound drop in blood pressure. It doesn't firmly at all put you into a category of atypical, but the prescribing physician or practitioner should kind of keep that in the back of their mind that you did have this out of proportion response to the medication and keep a closer eye on anything else that might emerge clinically. It may just be you're sensitive to dopamine agonists, and that's fine. Many people are. But it does, like I said, kind of put someone who prescribed it, if you do have an out of proportion response, to see maybe we are dealing with an atypical Parkinson's. No response or absence of clinical response doesn't put you one way or the other. Some people just don't respond to the medication. If you have the absent response to the dopamine itself, to the carbidopa levodopa, that's really the one where we use as the standard of potentially moving you somewhere down the spectrum.
So I know at the beginning of this conversation, we were talking about, just the delaying of diagnosis and, the importance maybe of sometimes seeking a second opinion. Some people are reluctant to seek out a second opinion for lots of different reasons. But I would love for you to kind of talk about the role of it. And as a physician yourself, if you're the one diagnosing and someone's like, well, I want to get a second opinion, how that feels. So
Yeah.
you think people are concerned they're going to offend their physician
So
sometimes.
if your physician is offended by you seeking a second opinion, then that should be a red flag to you that you should seek another physician. There should be, no one knows everything, no one knows it all. And I encourage patients to get a second opinion. One, if it's a difficult diagnosis and we are sort of hedging our bets and not 100% sure where we're going clinically. Two, if I can learn something from somebody else laying eyes on the situation, then that makes me a better doctor. If I lose a patient to the wherever they, sought their second opinion, then that's where that patient is supposed to be. I don't take it as a personal affront to me or being that I'm not a good enough physician or anything like that. People click. And you need to be someplace where you feel comfortable, where you're getting your, questions answered and you feel empowered. Likewise, knowing that I'm open and encouraging patients to seek the other opinion should they want it, that usually helps solidify the relationship that I'm not, I don't feel antsy or there's no angst or I'm not feeling, particularly off put by it. And that usually reinforces the fact that it's a good working relationship that I would have with the patient in that regard. I think second opinions are important at different stages in the Parkinson's treatment because everybody falls into their ruts. So if things are going along just fine and you've had a really good working relationship, but it's been a few years and not too many changes have been made despite being asked, like, is there something else I could do? Is there something else I could try? That is an absolutely appropriate time to say, okay, well, I think I'd like to seek a second opinion just to see what else is out there. Go for it. Because like I said, everybody has their treatment strategies. Everybody has their algorithms that they follow. And sometimes we get lost in them and don't necessarily think outside the box. And that's, one size does not fit all for everyone.
We had an interesting question. They want to know if diagnosis is a skill. Are you better or faster than when you were newly minted doctor out of school?
Yes, absolutely. I mean, it's like exercising a muscle. The more you see it, the more you do it, the better you get at it. And as I said, movement disorders is incredibly visual. So if you're used to training your eye for what's normally abnormal, then you can pick it up quite quickly. There are times where, I see people walking down the street and I'm like, that's somebody that I should probably be seeing in my clinic at some point. So as time has passed, I'm a better diagnostician now than I was when I first started because I have more confidence in my ability.
And I appreciate the fact that you said that it's not even just at the beginning when
Oh,
someone's seeking a diagnosis, but like throughout the journey, like
Absolutely.
that a second opinion might be beneficial.
There is, and also just for medical management, but uh, especially if you're thinking of doing anything more invasive, like a device aided therapy, thinking of having a pump or thinking of getting ultrasound or DBS, any procedure warrants a second opinion discussion because it is a procedure.
And, it's often where people don't necessarily see the movement disorder specialist first. They are diagnosed by a general neurologist and they're treated by a general neurologist for a period of time. And then, kind of like you were saying, as the disease progresses, things change. They might actually benefit from then an evaluation and second opinion from a movement disorder specialist if they had not seen a movement disorder specialist. And that's a value at that point too.
Absolutely, because treating Parkinson's with carbidopa levodopa alone is not incorrect at all. It's the gold standard, but there are other options available if it's not working out as well as the patient would like, or they're experiencing side effects. They don't feel like they're getting as much of a benefit out of it as they could. So there are things that can complement or be used in lieu of carbidopa levodopa. And if the general practitioner or the general neurologist, through no fault of their own, because they have a ton of things that they need to remember, aren't aware of the newer drugs or the combinations that can be used, that's where the specialist comes into play. As a movement specialist, I know a lot about a sliver of neurology. A general neurologist knows a lot about a lot of neurology. So it's two very different skill sets.
And, a comment came in, a second opinion on starting new drugs too is important. So going along with what you were saying. And then someone wants to know if insurance typically pays for second opinions, if you run into any issues with that.
So second opinions, yeah, usually is not something that insurance would limit you in seeking. If they're it obviously check with individual insurers just to make sure, but you can have multiple docs for the same thing. I don't encourage that simply because too many cooks in the kitchen then can become what you were trying to do kind of backfires and now you're confused because there are so many options. Be selective with the second opinions that you seek and try and focus on one set of recommendations and incorporate that. So if patients like see me and they see like two other movement specialists or me and a general neurologist and somebody else, I'll let them know. I'll be like, this is fine, but if we start to contradict each other in what we're saying, that's where you need to make a decision because that only becomes problematic for you.
Yeah. And I know you offer a telemedicine second opinion service. So can you explain what this is and who might benefit or could
Sure.
use this?
So, I am in my own practice now. I was part of a large subspecialty practice. I was part of an academic practice, and now I'm part of my own practice. And I am patiently waiting for my office space to be finished. My husband is doing the renovation and the work, so there's only so much I can I can push. So in that interim, what I've been doing is telemedicine. As I said, I've been an advocate even before the pandemic, so it's a medium that I'm very comfortable with. And I'm also doing home visits for patients who are local. I'm licensed in the states of New Jersey and Pennsylvania, so I can assume all care for patients in those states, prescribing, sending referrals, things like that. But a virtual second opinion is available to anybody anywhere, in the United States, abroad, however it might be. And the difference is I don't assume care of those patients. But what I do is provide a detailed summary of recommendations that they can then bring back to their local physician, nurse practitioner, PA, whoever is managing them for their Parkinson's disease. And so that's an hour-long visit. It involves review of medical records, and then in 6 months' time, a 30-minute follow-up visit just to see where people are, if they had any questions about of the recommendations or how it was implemented. So those are different strategies that can be helpful. And I didn't come up with this model. This model is based on something called Second MD, which is a model that is used in insurer contracts with different companies. So say like Merrill Lynch or I don't know why I thought of Merrill Lynch, but say someplace big like Merrill Lynch that has that offers benefits for their employees. One of the benefits they offer is this second opinion option where they can speak to a specialist, get recommendations, and then take it back to their local doctor for discussion.
And I think that's really valuable, especially for people who, like I said earlier, may not live anywhere near a movement disorder specialist, and they're trying to work with maybe a general neurologist, advanced practice provider, and, to be able to have that expert opinion and recommendations, I can see being very helpful.
So yeah, I mean, I hope patients do find it a useful service. So it's something that we're working through and experimenting with now, and it seems to be going okay.
Well, and there was a comment that you have a very nice looking front porch office.
Thank you. Thank you very much.
Well, and, I will, welcome any other questions that you might have for Dr. Farmer in terms of like this whole journey, some of the things that we've covered today. I know we've kind of gone from, just the struggle of being diagnosed to all of the variables that can impact that and how to maybe get to a diagnosis, to a second opinion on a diagnosis. So we still have a few more minutes if there's any other questions. I don't know if there's anything additional, Dr. Farmer, that you wanted to bring up that we haven't covered.
No, I think we went through a lot. The main thing is being your own advocate. So if individuals are here that have been well, diagnosed and are in an established care pattern, that's great. For someone who is newer to this journey, if you're not feeling that your provider is listening to you, if you're getting your questions answered satisfactorily, then it's entirely valid to, shop around, to seek out other docs or other providers, to make sure that to speak to other people in support sessions like this to see where they're going and what they're doing so that you can feel like you are getting the best foundation for your care that you can. Don't worry about hurting docs' opinions or feelings or anything like that. Are that's not something that should enter into your concern about your treatment.
And, speaking of treatments, and I know this comes up frequently in our programs, is, people wanting to know how acceptable is treatment outside of the traditional medicine,
Sure.
maybe complementary and alternative treatments, and your thoughts about that.
Absolutely. Again, I am a fan. But my background is osteopathy, so I'm a DO, and the mind body connection, I think, is an incredibly powerful tool that can be utilized. Exercise increases dopamine levels in the brain. This is something we know. It doesn't involve medication. It doesn't involve anything. It's a good, healthy lifestyle. It is part of that complementary way of treating neurodegenerative diseases along with diet, like we were speaking about. Now, there are additional complementary things that can be done, whether it's through supplements, whether it's through acupuncture, whether it is through Tai Chi, or whatever your flavor of complement might be. The thing that has to balance that, though, is there is nothing that we have that replaces dopamine. So while exercise can help increase the dopamine levels, if you're dealing with that deficiency to begin with, it's not going to make more. So we do need something to support and supplement it. And that is where the pharmacology comes into play. That doesn't mean you need to be on medicine that doesn't agree with you, that isn't providing you benefit, but while you're doing the complementary things, you should try to supplement it with some sort of pharmacologic support in some way. And if that combination works for you, great. If it doesn't, then you have the discussion with your doctor of what works best. Because there is also the concern for, false promises and false statements of benefit and things like that. If patients ever had to choose between medicine that has more established data versus a supplement that doesn't, and the supplement costs more, I'm not going to support the use of that supplement. If they are looking to try an experimental treatment, whether it's an infusion or, a transplant of some sort, we know that infusions of glutathione or stem cell transplants, things like that, do not have the clinical foundation that they should be standard of care. So that I'm not going to encourage. But if someone would like to, they don't like their carbidopa levodopa, but they'd like to try mucineprurines because they think they'll tolerate that better, I'm fine with things like that because those are helpful. And there's data behind them to suggest that it can be of benefit. Intranasal glutathione, the same thing. Certain anti-inflammatory supplements, N-acetylcysteine, SAM-E, whatever it might be. There is some data and to suggest that these may be beneficial. Should they replace things that have more data behind it? No. Can they be used in complement? Sure. It's a matter of balance.
Well, and I appreciate that because I think it's important for it to be holistic approach, and it is like there's a lot of things that we're trying to manage. So if you can have as many tools in your arsenal, the better.
Absolutely. Mm-hmm. Yep.
Well, I want to thank you so much, Dr. Farmer, for covering all of this. I know this is not something we really have talked about so much, about that whole journey and what all it involves, and just the importance of seeking that second opinion and what that might look like, and to kind of reduce some of the fears people might have in doing so. So thank you for your time and expertise.
Oh, you're so welcome. I always enjoy our conversations and education. So I'm happy to come back anytime.
Absolutely. Well, I'm going to invite everybody to give you that wonderful wave across the country of gratitude that we do. Thank
Thank you.
you
I love it. Yes.
so much. All right. Well, we'll welcome everyone to have a great rest of your day, and we'll talk soon. Thank
Okay.
you.
Bye.
Bye.